Welcome to End of Life University on YouTube. Today I'm sharing with you an audio recording of an interview I did with Dr. Nathan Riley. Dr. Riley is amazing. He is both an obstetrician and a hospice and palliative care physician. So he works with birth and death both in his career. He's an advocate for natural birth and natural dying. And we talk a lot about some of the problems in our medical system and what needs to be changed. I think you'll find him an amazing guest, and he has so much to share. So I hope you enjoy that conversation with Nathan Riley. And also be sure to subscribe to this channel by clicking the button down below if you haven't already. You can subscribe and follow the podcast as well, wherever you happen to listen to End of Life University as a podcast, and leave a rating and review there. That will also be really helpful to this show. And if you're so inclined, I'd appreciate it if you'd go to eoluniversity.com/support and learn how you could make a small contribution financially that will help keep this channel and the podcast on the air. So thanks in advance if you choose to do any of those things that will help us out. So now we'll move on with my conversation with Dr. Nathan Riley. Hello, everyone, and welcome to End of Life University podcast, where we share real talk about life and death. I'm your host, Dr. Karen Wyatt, and thanks for joining me here for episode number 253. Today, we're getting into a topic in the interview I'm sharing with you that is near and dear to my heart. We're talking about the Western medical system, particularly here in the U.S., what's wrong with it, how training tends to lead doctors astray, and some things that we need to do to make medicine better. And so I'm speaking with a very special doctor, Nathan Riley, who specializes both in obstetrics and hospice and palliative care, which is rare in my experience to meet a doctor who practices on the bookends, the beginning and the end of life, both. And he has a great perspective on how birth and death are similar, and some thoughts on the mysteries of medicine and of life and death and what we need to do to improve our medical care. So we're not talking about things like insurance payments and Medicare for all or anything about the nuts and bolts of the system. We're talking really about the emotional and spiritual aspects of medical care as it's being provided here in the U.S., and how we might change training for doctors and change the mindset and culture of medicine in order to do a better job for people at the beginning of life and the end of life, and then throughout life as well. And so for me, it was a really fun conversation, and I hope you find it of value too. I'm going to get into that interview right away with Nathan Riley. And as always, stay tuned after the interview, and I'll come back with a few announcements for you, and I'll give you my takeaways before I say goodbye. So here we go. Today, I'm happy to welcome my guest, Dr. Nathan Riley. He is a medical doctor specializing in both obstetrics and hospice and palliative care. He currently practices in Louisville, Kentucky, and is the host of the OB-GYN-WINO podcast. He's also an artist, a climber, and an environmentalist. And you can learn more about Nathan's work at nathanrileymd.com. And Nathan and I have had a couple of conversations by phone, and right away when we spoke, I just felt like we were kindred spirits, and that Nathan was the person that I wanted to have a conversation with about talking about what's wrong with Western medicine, really. And so, Nathan, I'm really glad that you've joined me today.
Karen, it's really great to talk to you again. We've had a couple of very long-winded conversations, but just because you and I see so eye to eye, and we've had such similar experiences, I guess, throughout our medical training and our careers. So, and I'm fairly new to this, but you and I somehow our paths converged.
Yes, it's been really interesting that we're from different generations. We really have trained in different eras of medicine in some ways, but have had so many similar experiences. So,
yeah.
Well, I'm excited, and hopefully we'll stay on topic and we won't veer off into hours long discussions today.
we could do a whole 12-hour podcast series.
We could. We could. Well, Nathan, first, I'd love for you to tell the listeners your story, because I'm always interested, especially by the fact that you've been attracted to the beginning of life and the end of life. So I want to hear all about how you got interested in medicine in the first place, and then what brought you to those two specialties.
Yeah. I guess when we're in high school, right, the kids that do well in science, and if they have the means to do it, they go into college, I guess, thinking they're going to do something in, at least a lot of us go in thinking we're going to do something in medicine. And I had no idea really where that was going to lead me. But my mother, she worked at UPMC in the Department of Internal Medicine as a nurse. And then she became a sort of an executive level administrator after years and years and years of time there. And so I would go to work with her, or I would go spend my summers doing their mail sorting or whatever. And you get to just see what the life of a doctor is. And, they're poised, they sort of walk with this sort of charisma and confidence, and people, go to them for their answers or to solve their big problems. And those things were all really captivating for me, and coming from a place of means. We had a very middle-class family that I came from. You always want to, quote, give back, and you want to do good. And then in college, I did all this traveling, and I very quickly realized that there's a lot of work that can be done on the health side of things. If you can provide somebody with, what I would say now, some improvement in their morbidities, right, which are probably the things that make people the most miserable, then you can do a lot of good for them. And so I started studying Paul Farmer's work and Albert Schweitzer's work, and I realized that there's a big leap into the social justice realm here if you want to do a medicine in that way. And so it let me do good and solve problems. And, I got through the medical school process. I was not everybody's favorite medical student. If I had to guess, I probably would say I finished at the bottom of my class, honestly, because people were just so tired of me asking questions and just the curiosity around every little thing, as opposed to, just take the test and get through this. And so, needless to say, at the end of med school, I was attracted to this sort of mystery around birth. Nobody's really exposed to birth. It's sort of stigmatized in a weird way. It's not something you talk about around the dinner table, and you're in med school and everybody has to see a birth, right? I mean, that's a bit of a rite of passage. And a lot of people right then and there decide, I will never, ever do that again. That was horrifying for me. And it's not like as little kids, we were in the delivery room or whatever for our little brothers and sisters. That just wasn't, at least in my generation, that wasn't really common. And home birth isn't very common. So I saw that and I was like, oh my gosh, this is really intense. And there's something really special and magical that's happening here. And then you move on to the next rotation, right? And you remember that from med school. And it was the only rotation where I really felt like super excited and interested in what I was going to find next. And so I pursued residency in OBGYN, and I really loved it. I especially loved the time that I spent with midwives, and the time I spent training with people who attended birth in the community and at home. And I then started, again, my curiosity started leaping around, and I was everybody's least favorite resident. So I've made a lot of whatever the opposite of fans are, and I wouldn't say enemies, but people that were just constantly rubbing their temples because of the questions I had and, my curiosity around things, and getting into the history of midwifery and the history of birth and sort of the human rights piece and the social justice piece there. I really became captivated with, the sort of the autonomy and the informed decision making and the right to refuse treatment conversation. And just because a woman walks into the hospital doesn't mean that we are now the captain of the ship and we have control over their body. And that became my big fascination. So from an OBGYN standpoint, that's actually what I do now, is I do a whole bunch of advocacy. And I have that luxury because I also decided to pursue hospice and palliative medicine for the exact same reason that I got out of OBGYN. And a big part of that was that I got to sit down and actually get to know people. And I realized that when I was on the labor and delivery, one frustration for a lot of my training attendings and my colleagues was that I really wanted to get to know this person's story. Why are you so afraid of this process? I know I'm afraid of giving birth, but what is it that has made us as a medical system so afraid of this process that seems so natural and physiologic? So you can, I'm sure you're already guessing, the jump from there to the medicalization and pathologization of death was equally captivating to me, So we have this natural physiologic thing, birth, that I think that we over medicalize. And then I get some exposure to palliative medicine through TED Talks and through the death of my own father halfway through medical school. That was the other thing. Anybody out there listening who wants to go to medical school, you don't have to do well on the exams to get into a good residency program and be successful. My dad passed away 2 weeks before the big licensing exam, and I passed, I think, by like 2 points. But again, you just have to pass that test to get on to the next step. But losing your father, it really forces you to contemplate what the heck you're doing here, And he was a big, strong guy that had multiple myeloma and went through 5 years of chemo and, quote, fighting it. And ultimately, cancer won, and we had to say goodbye to him. And towards the end of his life, he finally opened up to a palliative care consultation at UPMC, and the amazing team there got him to talk about all sorts of things. You don't expect your big, tough, blue-collar, Rust Belt dad. I'm from Pittsburgh. You don't expect them to talk about their emotions or their sort of fears about dying and their fears about their sins and their religious pretexts and whatnot. So I saw these in my own residency training. I then saw palliative care physicians. They're having these family conversations where they're telling this really scary stuff, and people are thanking them for saying it. And so there's a lot of parallels between the way that we practice birth, or that we attend birth, and we attend to death. And they've been equally interesting to me. And now I get to do both, which I think is fantastic. And apart from them being the two things we don't want to talk about, there's this spiritual something about them where I see them as two sides of the same coin. And if we pathologize them, we kind of fail to respect it. We through this like scientific materialistic lens, we just see this body that goes and goes and goes until we can't get it to go any longer. And then kaput, we have to close that up in a body bag and rush it down to the morgue as quickly as possible. And when we have that materialistic view of life, we miss that spiritual, that sort of sacred nature of both of those things. So, so that's how I got there. And I get to help people at the most vulnerable periods in their life. The scary sort of stepping through a portal that many women describe of birth, especially women who have chosen to not have any sort of medication, or who are having a fully natural, birth in the hospital. There's a something very spiritual there. And I watched my wife go through it about 4 months ago, and holy smokes, it's one of the most incredible things, not just because you get to see a baby come out, but because you get to see the person that you've loved we've been together for almost 20 years. And you get to see them become somebody new. The maiden becomes the matron, and this incredibly beautiful butterfly comes out of the cocoon. And you're like, I already thought you were amazing, and now you've done this. And you've watched them, they get this new glow. They have this certain confidence, this certain something about them. And I don't know, the whole thing is, I could go on and on and on about this, but there is something special that happens at these two moments in our life. And I get to attend to people at those vulnerable times. And it's the best job in the world, I think.
Well, I agree with you so much about the fact that the over medicalization of both birth and death shows, for one thing, the medical profession is just blind to the sacredness and really the mystery of both of those passages. And then also tends to remove that specialist for the patient. I mean, tends to medicate the patient to an extent that the patient and family themselves end up missing the sacredness also. And it's really sad to see that happen.
Yeah, it's in the way that we provide prenatal care, as with the way that we prepare families and people, each of us, with this sort of mortality piece, or in the case of birth, the birth piece, is to sort of prepare them to be afraid and to avoid it at all costs, right? And we don't really prepare people for the sort of, I don't know, maybe the magic alternative to that narrative. And that's part of what I think I've set out to do, is to sort of change that story a little bit. And we all love stories.
Yeah, and I think for one thing, we're afraid of pain and suffering,
Yeah.
and childbirth without medication definitely involves pain and suffering.
Yeah.
And
Right.
we use medications, hopefully, in a compassionate way for people who are dying, but it's still a passage
Yeah.
of pain and suffering in a way. And so it feels like some of our impetus to want to control every aspect of birth and death is that fear, the fear of anyone ever being in pain or having any suffering, and wanting to remove that. But we go so far that we end up destroying the beauty of
Sure.
those moments at the
Sure.
same time.
Yeah, and we see this every single day in labor and delivery units, as well as ICUs, or in, a patient who's on hospice or whatever. And my ideas have been changing about this quite rapidly. I'm only 2 or 3 years out of residency now, or I guess 3 years now, and I'm really starting to wonder. I have two very short little stories, but there's this one. I'm actually considering pursuing a PhD in this because I have so many ideas around this idea of the sort of role of suffering during these challenging transitions. And I know I'm not like the genius doctor to come up with this groundbreaking idea. I mean, the idea that suffering serves a purpose dates way back. I mean, the ancient sort of Buddhist tradition of utilizing suffering as a means of working through the wheel, right, to eventually get off of that samsara and work through our dharma and live out our purpose. Suffering is a key component to that. So when I was in fellowship, I remember hearing a podcast where this was gentleman who's an ethnographer. He had studied pain management at the end of life in Buddhist practitioners living in Thailand. So Thai Buddhists who refused opioids. And from a Western medical standpoint, how could you possibly refuse opioids when you're riddled with cancer and you know that you're in every type of pain, nociceptive pain, neuropathic pain, you can't breathe without pain. Why would you turn that down? Well, if I were to take that medicine and it would numb me from this process of feeling the pain, if you equate the pain to suffering, and suffering is my task, then you've disconnected me from the whole purpose of this whole transition in the first place. And I found that to be so, for me, it's like, I'm using air quotes here, but that's like such backward thinking, because nowadays we treat pain as a vital sign. And yes, it is important to check in with people and to make sure that we're treating their pain adequately, and that we're not giving pain medications to some races and neglecting other races because we think that some people can take more pain. I'm not saying that. What I am saying is that if we look at this as a strictly materialistic, or through a strictly materialistic lens, we miss the potentially important emotional and spiritual aspects of what it means to die. And there's one little mini story I'd like to share, Karen, because I just heard this a couple of days ago. There was an interview with a gentleman named Zach Bush. He's an MD. He's a hospice and palliative trained internist, I believe, and he's also boarded in endocrinology, and he does a lot of lifestyle medicine work, and he works with regenerative farming. And so I was a little bit surprised to hear this podcast interview with him, where he told this really interesting story. It was about it was a sort of recollection from an Austrian forester by the name of Victor. Shoot, what's his last name? Victor. It's escaping me. I'll have to find it and let you know. But Victor Schoberg or something like that. But he was a forester, fourth generation forester in Austria, who had sort of in sequence, the men in the family had cared for as a forester this plot of forest in Austria. And he had made a lot of observations, so much so that he actually wrote a book. I think that was called Learning from Nature, or was it maybe a biography about him. But in his observations, he noticed that a fish would be swimming in concentric circles and sort of like a tightening spiral in the water from his vantage point. He could see this. He looked at this lake or pond or whatever every single day and would see this happen. And then he eventually started noticing eagles doing the same sort of patterns over the water. And if you watch long enough, you notice that the eagle and the fish have this tightening spiral where it makes these tighter circles as the eagle gets closer to the water, and the fish just keeps swimming closer and closer until finally they meet at the center of this giant cosmic circle. And the eagle grabs the fish out of the water. And after having watched this so many times, he realized that the eagle is not even dipping into the water. The fish was actually appearing to jump out of the water into the talons of the eagle. And as the eagle's flying away, you can then imagine, what must it be like for that fish? Like let's give the fish like the human capacity for thinking, and let's allow that fish to now look down at this body of water that's getting smaller and smaller and smaller as this eagle flies away. And imagine the liberation that fish might feel having moved on to the next transition, right? That fish is going to die. So we would say, oh my God, the fish is going to die. Let's get that eagle down there and get that fish out of its talons. We all think this, like when we watch Planet Earth and all those movies where there's like the predator and the prey, and like you're rooting for the prey to get away, because heaven forbid that animal's going to die like that. And that has to be the worst thing in the world. But in this case, what if this fish is actually looking down and saying, oh my gosh, I've been liberated from this little tiny tank I've had this whole life. Look at everything that's around me. I mean, what possibly could come for that fish later, apart from a transition to some other place? And again, I'm not encouraging, physician assist or aid in dying or suicide or any of these other things to push the process along. But what if we were to reframe that story? What if this is just the very beginning? What if death is the beginning and birth is the end of a previous sort of planeswalking, right? Whatever that might mean. And this isn't even a religious conversation. This is just a reimagining of the narrative that we tell ourselves about what happens before and after death, or before and after birth.
And I love the thought of that the eagle and the fish are connected, and both and their paths, their trajectories are connected. They are going to intercept and meet at some point, and it's as if both of them know that, as if they've been on this path all along, and they're both going to come together at that exact moment.
Yeah. It's a beautiful thought.
Yeah, it really is. And I definitely think you're so right that, our entire society is death phobic and would avoid death at all costs if possible, but particularly medicine. That's definitely the focus of medicine. But it leads us to so many of the problems that we come to in medical care. It is not being able to meet the true needs and wishes of the patient, not being able to listen to those wishes, and not even being able to discuss death and dying with our patients, because we're constantly trying to push it away and trying to defeat death. So we can't have a conversation about it.
We can't. I mean, I know we're going to get into this a little bit, but doctors, for some reason, have assumed this role of assuring that we have a good outcome. And I'm using air quotes again around good outcome. We have a good outcome as the result of every action that we take. And I have a different opinion. That's what we were all taught in residency, and that's what we all tell ourselves to make ourselves feel better when we take the helm of the ship that is a patient's medical care. But we have one job, and that job is to provide evidence-based recommendations using non-coercive language, and then to support our patient's decision in a non-negligent manner, period. And unfortunately, the way that we're trained is to carry a hammer around, and everything that looks like a nail, deserves a hammer. And if it doesn't look like a nail, we'll try to pretend it's a nail, right? We'll use the back of a pair of scissors or something, or we'll just hit it harder, we'll find some way to make this sort of myopic view of our role here, just make it work, right? Because if death is the ultimate failure, then we're really kind of out of tools, right? We all know that we're going to die. We haven't yet quite reached that level we haven't transcended to that level of godliness. We can telecommunicate across the world instantly, and you and I can record this message while you're on the West Coast and I'm here on the East Coast. This is all very fascinating stuff, but we still haven't figured out a solution to this pesky issue of death. And in the birth world, this becomes really, really problematic, because a lot of women are being traumatized through the process of having a baby. And it comes from a sort of ignorance towards maybe the experience of being a woman who's carrying a baby and then having a baby come out of them and them stepping through this portal, that spiritual side. It's a huge part of it is that we neglect that. And what we use to justify that and to make this, again, a very materialistic thing is we use this phrase, healthy mom, healthy baby, right? So it's okay for us to traumatize a person with a baby if we're doing it in the name of keeping the baby healthy, and we forget that a person still has the right to refuse treatment. But again, it's that sort of specter of death. Like, death is around every corner when you're on the labor and delivery unit. We are prepared for that 1 in a million, 1 in 1,000, 1 in 10,000 things. But we forget that there's a person here who's being traumatized every single time we lose sort of that they're no longer the center of our attention, right? And the baby really does come second. Even our ACAR, the American College of Obstetricians and Gynecologists, agrees that a woman still has the right to refuse a C-section even if you think that the baby's going to die as a result of her refusal, as long as she's of sound mind. That is her prerogative. But I mean, this story around death is played out in ICUs every single day in my life. I mean, I do mostly palliative medicine now, so there's a joke. There's a joke I heard from an oncologist in fellowship, which was, there's a bunch of oncologists sitting around the room, around the table at tumor boards where all the oncologists get together and discuss specific cases and decide what the best treatment is. Should they get surgery? Should they get chemo? Should we get radiation? Whatever. And so this person's name comes up, Mr. Adams or whatever. And one of the oncologists speaks up and says, "Oh, Mr. Adams is down in the morgue. He died yesterday." And the other oncologist says, "Well, he's due for chemo. Let's go down there. We got to get down there. He's due. It's 9:00. So they all rush down there with all their chemo drugs and their IV poles, and they go down to the morgue and they pull open Mr. Adams's his drawer where his body should be, and there's a little note in there. And they reach down and they lift up and open the note, and the note says, "Gone for dialysis. Be back in an hour." So I don't mean to throw oncologists and nephrologists under the bus, because I have many, many friends in those fields. The reality, though, is that what we do is we focus on the individual organ system, and we forget that there's a person here, and a person dying is not a failure. A person dying is biology, and that in and of itself is materialistic, right? But again, I guess to your point, if we lose sight of, or if we stop looking through a more emotional, psychological, psychosocial, spiritual lens, we just see a body going from point A to point B, or I should say point B, birth, to point D, death. And everything in between is just meant to help us stretch out that time between those 2 points, as opposed to living better and actually considering what's going to come after this. And I think it would really do physicians a great deal of good to start considering that.
And I wanted to hear your thoughts as someone who fairly recently has been through medical training. Where do you feel things go wrong in the training process? At least that's what I believe, is that it starts from day one of medical school. Our whole training process leads physicians into this reductionistic, materialistic view of medicine. And I just would love to hear from your experiences where you feel that has, where are we going wrong, and how are we leading doctors off in the wrong direction?
That's a really good question. And unfortunately, I wish I had some really, higher level way of understanding it. But unfortunately, I don't really think that it's changed too much over the past 100 years. I think that in training, as you know, residency is really hard, and people are burned out from the first 2 months on. Their hair doesn't look quite as good. They're not as quite as clean shaven. They're not as clear headed, and it's a go mentality. And I think that a big part of what changes for a person, because everybody who goes into medicine is a good person. They all have similar story as to what I had, as to why I got in, right? You want to do good, you want to solve problems, you want to help people, blah, blah, blah. We've read it 1,000 times in all the personal statements. But what happens is it gets kind of beat out of you, because you're sort of you're sort of forced to that. In OBGYN, it's like, the joke I say is, you know, you're supposed to memorize 500 things and you're going to repeat those things 500 times for the rest of your life. I think Brad Boots Taylor, an OB in Atlanta, I recently met, he said this. And it's like, you know, those 500 things, you're just going to memorize them now, and then you're going to regurgitate them for the next 40 years until you retire. Heaven forbid you have your own thought for once. And that's because there's a lot of stuff to know. So there's this go, go, go mentality. Learn, learn, learn. 70% of our training is surgical. So you're in the OR, you're reading books after work. You're told to neglect your wife and your family because this has to come first. And you lose sight of like what a person is. You know, you yourself are dehumanized. You're told you're not supposed to poop, pee, have sex, laugh, have joy, cry, have feelings, get too attached to people. You're not supposed to have romance outside of work. I mean, these are all the things that make us human. These are the rich things. Working is not what makes life fun. I hate to say it. I've tried it. It's not all that it's cut out to be, but all those things that make us human are also the things that make our patients human. And when you stop looking at those things, when we see ourselves in the mirror, we also stop seeing this in our patients. So I think it very quickly derails us from this path of taking care of people, to this like fast medicine. You know, there was a book by Victoria Sweet called Slow Medicine. She also wrote a book called God's Hotel. She's a great writer. I think she's a Pulitzer Prize winner. And that book, Slow Medicine, I thought was her best work yet, because it talks about how we've reduced taking care of a person to looking at a medical record and checking these boxes, these like nebulous things, where, you know, now taking care of a person means looking at the imaging, doing the labs, making sure you ask the right questions about the review systems, checking just enough body parts so you can bill for it, right? And then you move on to the next patient, and you make sure that you put your orders in, right? And the pharmacy has to clarify it. And you may not even really get to know who this person is that's in the bed, but you know, despite all of our sort of harping on social determinants of health, and our chaplains harping on how a spiritual belief system may be sort of the root cause of some of their maladies, we just aren't taught how to do that in training. So you have to learn that later. And I mean, I guess to make that, I'm sorry to cut you off. Go ahead, Karen.
I was just going to say, I think when you are overworked and exhausted, it's much easier to focus on lab results and x-rays, to look at those tangible things on paper, than it is to actually sit down and have a conversation with a real person, because people are complicated and messy, and they bring up all kinds of issues and problems, and no one feels like they have the time or the emotional bandwidth, I think, to deal with that. So it's so much easier to just retreat with the chart and look at all the numbers, make decisions based on that, and ignore the person in the bed.
I mean, I absolutely agree. And it's not like there's a reward system in place where people who do that are actually kind of validated, especially in residency. If you're not moving as quickly as possible and as productive as everybody else, you're seen as incompetent. You're seen as maybe you're not cut out for this. You know, if you're not acutely running around like a crazy person with a chicken with his head cut off at all times, you're, quote, not taking it seriously. Or if you're not stressed in the operating room, you must not be that concerned. But if you're stressed out and you're doing a surgery on somebody who's awake, if you're stressed out or talking about things that are not related to this very special moment, then you've kind of missed the whole thing. She doesn't care she doesn't only care that her baby is okay and that she's okay. There is more to this. She's having her body cut into, and a person is being removed, and she's awake during the whole thing. So if you forget that, and you just focus on the sort of carburetor inside this little tiny incision that you've made, you're going to miss that. And so nobody really rewards you for taking a step back and trying to slow things down. And that alternative path is probably the way out of this. I mean, it's probably the way to fix the medical system. It's probably the way that we sort of start to rebuild trust between physicians and society. I think that one major issue is that we're not really modeled this. You know, I don't know what your experience was like, and I would be very interested to hear how your experience compares to what you've heard, you know, about my experience. Nobody really modeled empathy for me. And, you know, what we're taught is you have to you have to say words that tell them you're listening, and you have to make eye contact. You have to position your legs like this, and you have to sit on the bed, and patients report higher satisfaction scores when you do that. Like, it's reduced to such this like sort of reductionist view is so, it's just devoid of any human compassion or human connection. I'm really good at making friends in the bar. I can sit next to somebody and we will be exchanging phone numbers by the end of the night. And I don't mean I'm going out picking up chicks. I mean, I'm at the bar and talking to some random guy and we will become friends. I mean, there's a way that some people can be, and that's not really modeled within the framework of medicine. Like the medicine comes first and getting to know the people comes second. And in order to truly empathize with a person, you need to actually be there and be open to whatever it is that they're saying, whatever it is that they have to throw at you. It's different from waiting to talk, waiting for your opportunity to respond or to defend yourself or to fix their problem. My wife and I have worked on this for years, but if she ever comes to me with a problem, my Mr. Fix-It brain jumps on an opportunity to offer a solution even before the fifth word is out of her mouth, because that's what I've been modeled my entire life. And it's taken a very empathic, very patient person like my wife, who's one of the most incredible people I've ever met. And I have so much to thank her for, over the next 50 years that we're together. And one thing was just, I'm not coming to you to fix my problem. I'm coming here just to be heard. And I just wonder, in medicine, in birth or in death, I wonder how much better could things be between, even for you as a practitioner, if you just got to know this person and listen to them for 5 seconds, 5 minutes, let's give it 5 minutes of uninterrupted sort of discourse from them before you even offer a solution or you even offer any sort of objective insight. You know what I mean? We don't really have that modeled.
Yeah, I think there's a fear of that level of empathy. On the one hand, a fear that the physician will lose objectivity if they actually care too much about the patient, which I never found to be a problem. I actually found the fact that I cared about my patients made me that much more determined to figure out what's going on and to want to help them. But I think there's also a fear of the pain you might feel if something goes wrong. If that patient does die, the pain that you might feel from a patient that you've gotten close to could be so much greater than if you keep keep your distance from them. But that's just so very sad because getting to know those patients and getting close to them, that's actually what's enriching and nurturing about being a doctor. That's actually what makes the work gratifying and worth doing, in my opinion.
Yeah. I agree. I agree totally.
Well, you've mentioned social justice a couple of times and your interest in social justice. And I feel like that's an elephant in the room right now that I just need to bring up and talk about, because as we're recording this, we're not only in the midst of the COVID-19 pandemic, which we know is disproportionately affecting racial and ethnic minority groups, but we're also in the midst of going through a few weeks of protests over the death of George Floyd. And so racism and implicit bias, and white privilege, those are things we're all talking about these days. And I feel like what I'm really working on right now as the systemic racism of our society is in my face. I'm really looking at my profession and the fact that there are such glaring health disparities for racial minorities. I can't get past that. I just want to know how you feel about it, because you care about social justice too, but that something is wrong with our profession. And this whole idea of not getting to know people and not having enough empathy for people. I feel like that is our implicit bias is part of that problem as well. I don't know. Tell me what you think about that.
Oh, Karen, I have a lot of thoughts. So I live in Louisville, Kentucky, where next to Minneapolis, Louisville kind of blew up, I think, second before it really, I don't even know if I have it in the right order, but it was right around the time that George Floyd was killed, that protests on behalf of Breonna Taylor, who was a local Louisville woman who was killed during a sort of, I guess, a narcotics raid where they had a no-knock warrant and just knocked the door down, and thought they were going to break up some narcotics ring, and she was killed in the process. And of course, she was actually, I think, an EMT or a paramedic, and the whole thing was just like ridiculous. But it really never bubbled up to the surface quite like it could have. And then the George Floyd thing happened, and people then took that opportunity to just pile the two together. So we've been protesting here for weeks, and since the George Floyd incident, and I've been down there. I've been providing medical care. I have a great group of friends here who feel equally sort of like we got to use our white privilege for something, and we need to hold space and stand by in order to help in any way we can. And one thing that's emerged for me is, because you're right, it's so interesting that we have this COVID thing while we're dealing with the George Floyd and the continued police brutality and overt racism in our nation, which is, by the way, seen throughout the medical system. And I'll get to that in a second. But the feelings I have about COVID are that it's amazing how we can have an entire global effort concentrated on one issue, such as COVID-19. And I think it's because it presents a very obvious threat to our lifespan, right? Like, as a species, anything that's going to take our life needs to be destroyed, whether that's cancer, whether that is, I don't know. I mean, you name it, right? If your kidneys are failing, then let's just replace the kidneys. You know, I mean, we have this mindset that we're going to be able to eradicate anything that threatens our life as individual humans. And it's amazing to me that for several hundred years now, we've been facing racism. We've been facing rising rates of suicidality, depression, anxiety, child abuse, sex trafficking. I mean, you name it. How about like impending ecological catastrophe? And we can't seem to muster up enough of a collective effort to even curb some of those problems, let alone eradicate them. And so my thoughts are that, okay, COVID, there's all this unrest, right? There's a lot of people in our country, especially, who are so poor and so disenfranchised that they have absolutely no power in this world. And now that we've been faced with this COVID thing, it gives us the opportunity to put that unrest from all of these disenfranchised people, or people that are just unhappy, right? Like people, we know that we have all these big issues that I mentioned, but we don't have any tools to beat it. COVID offers us a target for all of this unrest, and it allows us to put all of our efforts and energy into this thing, right? And you know, we've never lived in a time of greater creature comfort, and yet we are all in so much pain, emotionally, spiritually, psychologically, etc. And this COVID thing let us get behind something and aim our guns of control at a thing that potentially will make our lives better and help us live longer. In the meantime, nobody's talking about the fact that millions of children worldwide are struggling to have a bite to eat, or that, you know, addiction and depression and all these, and homophobia and racism and all these other social ills have just been allowed to perpetuate. And it really gets me thinking. Since you asked, I'm sorry that this is a long-winded answer, but it really gets me thinking that in order for us to change those things, we you know, COVID is this like foreign invader. It's just like the terrorists, right? Like, we can always aim our missiles elsewhere, but in order for us to change how we behave from the standpoint and the viewpoint of racism, just that issue alone, or the ecological disaster that is awaiting us in the next 100 years or whatever, we have to actually turn those missiles around and face ourselves. And that is extremely challenging for people to realize that they have to actually look at who they are and change who they are and who they've become. You have to change not just your behaviors. You don't just have to try make this a new habit this month or a New Year's resolution. We have to change our entire paradigm of how we treat one another. In medicine, unfortunately, in order for us to be better, we have to change who we are. And that this goes for how we treat birth, how we treat death, how we treat women, how we treat Black women especially. And that's going to change. That's going to require us to not make excuses and to not say it's because of education or the non-compliance or that they're, quote, a challenging patient. It's going it's going to force us to reconcile the fact that we are overtly racist and we have compassion fatigue for many, many, many people out there that really, really need us. And as physicians, we can do much, much better.
And so I guess this is something I've been coming to and saying is that we have to start with ourselves. We each have to really look within and do our own work and uncover whatever biases we have within ourselves and work with those, because we can't hope to change the system. That's a huge task. But if each one of us could change ourselves, we would actually make progress, I think, in that area.
Yeah. I mean, yeah, 100%.
Well, we've talked about this idea of having a more natural and physiologic birth and death, and how medicine over medicalizes and pathologizes both birth and death. And what thoughts do you have about how can we restore birth and death to, I mean, I always imagine in the past days when there were midwives in the community, but not really a lot of medical intervention other than a midwife who was there to assist the process. And how do you feel we can kind of restore some of that natural process, both to birth and death?
Well, I think we just need to stop acting as if we can control nature. I think it comes down to this very simple sort of twist in our narrative about the purpose of human beings on this planet. And I think inherent in the message of authors like Daniel Quinn, Charles Eisenstein, Daniel Quinn wrote my favorite book called Ishmael. Charles Eisenstein's a prolific writer and sort of thought leader within the sort of ecological and sort of humanitarian imbalances in the world. And he wrote an article called The Coronation. And, you know, this idea that we are separate from is implicit within this sort of story we tell ourselves, that to die is to fail. And it's very applicable to the birth process as I've described, but it's most easy to describe around the time of death. And so I'll elaborate a little bit on that. It's if death is failure, if the failure of an organ system on the part of a nephrologist, if a patient is going to die as a result of their kidney failure, for physicians and other practitioners to continue to act as if that was their fault, that kind of needs to stop, right? It's not just an ego thing. That person actually is being made to feel like a failure if they don't offer this treatment, right? Which is, in the case of end-stage renal disease, would be dialysis. You've replaced their kidney function. We don't have to offer it. In the same way that when a person's lungs completely fail, especially if they have widespread cancer, we do not have to offer CPR and resuscitation. We don't have to offer intubation, which is when they put a tube down your throat and they artificially puff air into your lungs in order to keep oxygen going in and CO2 coming out. We don't have to do that. And in many respects, what we do as a society, we've trained one another to think that we as individuals need to choose to do those things. And so we kind of just need to give everybody a break. You know, we need to respect patients' decisions when they say, "Doc, that chemo really sucked." And a hypothetical I always give people is, if you could live 6 more months and have your symptoms under control and live out your life hanging out with your grandkids, feeling good, living your best life, or I'll trade you that for 12 months. But the trade-off is that those 12 months are going to be miserable. You're going to spend all that time in the clinic. You're going to be getting chemo infusions. You may need dialysis. You may be in the hospital. You may be on a ventilator, right? During those 12 months, we're going to be going as hard as we can with these very toxic drugs, and we're going to try to get you more time. you'll get more time as a result of maybe all those efforts, or maybe not. But let's say you did get more time in this hypothetical. Which would you choose? And I'm surprised by how many people actually struggle with that decision. On the other hand, there's some patients who are very they're very adamant. They're like, hell no, I'm not getting chemo. I went through this with my mother or father or whoever, and that was terrible. And you're telling me you want me to go through that? Hell no, I'm not doing it. I just want to go home. Give me hospice. I can't tell you how many nurses or physicians or whoever call me as the palliative care doctor and want me to kind of talk sense into the patient, or they're just in total disbelief that this patient wouldn't want that. And I think we owe it to one another to just sort of respect this process. You know, there's a lot of people, religious or otherwise, who end up in a place where they say, I've lived a good life. I want to go home. I don't want to be in the hospital anymore. I'm going through this with my grandfather and grandmother right now. My grandfather turned 100. He turns 100 tomorrow, believe it or not. And we were in DC celebrating his 100th birthday this weekend with the family. And, you know, we're all like, you know, cheering and hooting and hollering. And he has to come out of his assisted living facility. He can't hug us because of COVID, and they don't want him to bring germs in, right? So we're kind of standing 6 feet away in this weird circle. He has a face mask on. The poor man has macular degeneration, has only a sliver of vision on his right side in his peripheral. And even that's kind of cloudy. And, you know, how does it feel, Grandpa? How are you doing? You know, what's your advice? And all he could say with tears in his eyes is, being 100 is really sad. And, you know, he has my grandma. My grandma's has dementia. And the reason I'm telling this story about my grandfather is that my uncles have actually we've had a tough past 6 months or so. And now everything's okay. But I had to have a really hard conversation about what it would mean for them to go to the hospital. My grandmother, even before she had dementia, was adamant about not going to the hospital. But my family still feels compelled to do that, right? And she's been saying, I do not want to go to the hospital. I don't want to be there. I'm going to leave anyways. Don't take me there. And so when we had to have a conversation, I said, what could happen to her that would make you want to take her to the hospital? And they said, well, I mean, what if she falls? I said, they're not going to do anything for her. Well, what if she breaks a hip? They're not going to operate on her. She's 94 years old and she has dementia and she's sick. You know, they probably aren't going to do anything for her. They may just send her home. Why even take her there? She might get a pneumonia or a bug or something and bring it home, and then she's sick with something else. And so the reason I'm saying all this is to illustrate that we have to kind of let people take control of their life. Like, they've 4 years. I think she probably knows what she wants, you know? And that was before she had dementia, of course. And so now you could argue she doesn't know what she wants. That may be true, but she told us very clearly 4 years before she had dementia, you know, when we last took her to the hospital when she was 80 something, that she didn't want to go. And so when a person says, I don't think I want that, we have to respect that. We shouldn't be convincing people to do things that they don't want. We need to give them a recommendation that's evidence-based, and give them like real odds. It's not on us to make sure that there's a good outcome, especially if that good outcome means that you're going to defy death. And yes, it's really, really hard. I told you about that story of a lady today that I had to compassionately extubate, and she's alert and she's looking at me, but she's not getting better and she's getting weaker and she has advanced cancer all over her body. And that's a hard thing to do, but we also need to embrace what people want to have happen. And the same goes for birth. If a woman wants to have a natural birth, why are we pestering her with what we think about her ability to have a baby vaginally? Or why are we pestering her about the need for a C-section? She does not want a C-section. And even if the baby dies, whether it's a cultural or a spiritual belief that she has, that's her prerogative. The fact that a baby dies we're not going to eliminate all probabilities, you know, or all risk in childbirth. It's just a part of human nature, in the same way that living a life necessitates that you're going to die at some point. And we just need to respect that. So I guess the nuts and bolts of how we make that happen, I think, starts in our residency training. But and that's a whole paradigm shift we're talking about, Karen. I don't know. I'm curious, what are your thoughts about what can happen in order to maybe restore some of this natural appreciation for natural physiology?
Yeah, I would love to see, in terms of medical training, every student and resident just being exposed to natural dying. I mean, being able to witness
a hospice death, someone dying at home in hospice, and seeing how
Sure.
beautiful it is, because it seems like so foreign to most residents in training that someone's dying at home. I mean, I just think they can't even imagine what that's like. And so I'd love to see all doctors in training to be exposed and to see what's possible, just to have a different view of it. But then our
That's a
whole
great point.
society needs more exposure also to death and dying. And we need to embrace it as a society as just a natural part of life. Because I think patients as
Yeah.
well sometimes come in and they want everything done and they ask for everything possible to be done because of their own fear of death. And doctors are not very good at leading them through that fear or helping them draw any other conclusion.
Yeah, you bring up a really, really great point. I remember in my residency training, so many little kids are being rushed out of the room as a baby was coming. And then there's certain cultures in which that's like the little kids just playing on the floor over there, where mom's screaming and huffing and puffing and going through this process, right? So that little kid is not paying attention. It's not a sexual thing. It's not him seeing his mom naked. Like, we also have to kind of get over that, honestly. But the fact that a family would want their child at the birth of his baby brother or sister, that shouldn't be a taboo thing. Like, this should be something that we can talk about. This should be something that we can be exposed to. And likewise with death, I remember in fellowship, I had a gentleman who passed away like within 30 seconds of me arriving. I said hello to his nephew, who I had gotten to know as the doctor. I was visiting every week or two, and they got to know me over a period of time. And his nephew said, "Oh yeah, my uncle's ready for you. So happy you guys are here. Come on in." And we took our shoes off. We tiptoed into his room, and he was laying in his normal, like, decubitus on his left side, and he had his little fentanyl and midazolam buttons, and he was just hanging out there. And I looked over, and my attending was coming in behind me, and I was looking at his face, and I could just tell. I could just tell something had changed. Like, I think he died, and he was just alive a second ago. And so, sure enough, we auscultated, and it was, I mean, he had like a couple little flutters in his carotid artery, and then he was gone. And we just sat there for a moment and just sort of held space for what had just happened. And of course, people, I think his sister or his niece was there, and she had said a prayer. And immediately the family was prompted to say, well, okay, so we have to call the mortuary, and we have to call these things. Like, they had those lists of phone numbers, like a bam, 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 bam. We have to do all these things. And the same, so like the idea being, like, let's clean this mess up, and let's move on. Like, let's get this dead body out of here. This is too morbid. We shouldn't be around this. There's disease, and it's all these like funny things start popping into our heads, as opposed to just sitting there and being with our loved one when they pass away. And you never see that in a hospital. But likewise in birth, interestingly, that same day I went to the hospital because I was on call as an OBGYN, and I had to go right in for to attend a birth. And it was an unmedicated birth. I still remember it very vividly because I had like all of my street clothes on when I ran, and they were like, "Oh, Dr. Riley's here. Dr. Riley, come in." And I threw gloves on, and I was there. Of course, doctors don't do anything for the majority of births, right? We say we deliver it. I'm using air quotes, but Rebecca Decker wrote a great book, "Babies are not pizzas, they're born, not delivered." And the majority of the time, you don't do anything, right? That's the little secret we have. But after a baby's born, to just sit there and to hold space and just to be there, as opposed to all this like funny stuff we do. We want to get blood pressures and check the rectal temperature of the baby, and we want to dry the baby off and put a little hat on it and wrap it up like a little burrito and make it all clean and cozy. Like, you don't want to see all this gross stuff. This is it's yuck. It's like part of this story I've been telling about the unhygienic nature of women, right? Like, it's like we have to just get over that and just and sort of embrace what this moment is. And I guess in order to do what you and I both need to happen, which is needs to happen, is sort of exposing people to a natural birth or to a natural death. We also have to kind of get over the fact that these things are taboo and that they're gross and whatever. There's I'm sure you've heard about the death over dinner movement. I've been talking about having that for months here, but then COVID happened. And so I'm still looking forward to hosting it and having some of my closest kind of most open-minded friends get around a dinner table, and we talk about what we want our tombstones to say. And we talk about what it would mean if we were to die right now, and what sort of impression do we want to leave on people, and what sort of things are we afraid of in the afterlife. I mean, to not talk about it doesn't mean you can avoid it. You can't hide under the covers, right? So maybe adding on the exposure to the natural death and the natural birth, maybe also from a societal standpoint, getting people to talk about natural birth and talk about, I mean, even things like menstruation, and getting to talk about how freaking awesome women are and what the fact that they can do this incredible thing, and to talk about how incredible maybe death will be, and maybe what comes after this. Maybe there is something really cool that happens. It's not just pow, you hit a wall and it ends. I mean, or maybe it is, but we don't have no proof one way or the other. I will say that people that come back after being resuscitated, they're in the ICU and they've had their CPR and everything, they come back and they say, man, I got to see all the people that that I've been missing for all these years. You know, they end up in sort of that, if you want to call it heaven or whatever, but there's this, the spiritual being leaves the physical body and it goes elsewhere. And maybe what comes after isn't as bad as we all think. But yeah, I think it's going to be, you know, a multi-pronged approach, Karen. We're going to lead the way.
Yeah, exactly. We need to reclaim birth and death, like you said, the two sides of the coin, and how it could change everything in our society if we just had more comfort with the naturalness of those two passages, and the sacredness also. Like there's sacred passages where we pierce the veil, we come into physical form, and then we leave physical form. It really is. It's miraculous and mysterious and beautiful.
Yeah, it is. It is. You know, and even as you were saying that, I was thinking, man, everything we do is unnatural. We're in the garden and we're weeding. We're ripping out other forms of life in order to have our preferred forms of life grow. I mean, our whole kind of paradigm has to change around the sort of natural. And the natural is not always better, depending on what your outcome is, your metric is there. But man, it sure beats a lot of the alternatives. The natural way of doing things really does. Nature has figured this out for us, right?
Yeah, so true. Yeah, because birth and death were happening a long time ago, from the first human that walked the planet. So
get a lot of practice.
Yeah, oddly enough, without hospitals and doctors to take control.
It's unbelievable. Yeah, I don't even know anybody. I can't name a single person who had a person die in their home who didn't maybe immediately have the, like, get everything rolling right afterwards. Like, I've never heard of that. But I feel like if anybody out there is listening and you care about me, that's what I would want. I would want you just to, like, take a moment and, like, crack open a couple beers, some wine, play some of my favorite music. I'll have a playlist ready for you. And just like, enjoy me, like, just celebrate me, tell funny stories, make fun of me, roast me. I feel like that there's also a way to celebrate the what transpires after death. I mean, the whole idea of a funeral process, and we're going to make the body look pretty again, and we're going to make it. And my dad didn't look anything like the way he looked when I remembered him. Whenever they beautified him, right? The morticians are amazing at this. But even just being with mortality, like, it's okay that we die. If it's not okay that we die, then it's, how can we live?
Yeah, exactly. Well, Nathan, it's been so much fun to talk to you once again. I really enjoy our conversations, and I want to thank you for taking time out. I know that you're really busy in your life right now with a new baby at home and working a lot of hours, so I'm grateful that you spent this hour with me.
Yeah, no, it's such a pleasure. I would love to talk more about any of these things at any time. And if we have the opportunity to meet on the West Coast, I'll be there.
Yes, absolutely. Well, I'll remind the listeners that I'm talking to Nathan Briley. His website is nathanbriley.md.com, and he's the host of the OB-GYNO Wino podcast, where I understand fairly large quantities of wine get consumed during each episode.
Yeah. Oh, yeah. Actually, the new website is obgynowino.com, but Nathan Riley MD will direct you there. And,
okay.
And it's an OBGYN related podcast, birth advocacy. It's also a review of some of our sort of standards of practice and care. But I get a little soapbox there to talk about a lot of these things as well. So, yeah. So you can find me there. I'm not on any social media. I deleted everything. So.
Oh, I envy you.
I'm sorry.
It's a great idea, actually.
Yeah. With a baby coming, I figured let's just narrow my attention a little bit further.
Well, enjoy the rest of your evening, Nathan, and thanks again. And we'll be in touch, of course, and we'll end up doing another episode down the road, I'm sure.
That would be great. I would love that. Thank
you
so
much,
Karen. You take care.
All right. Thank you. You too. Bye.
Okay, bye.
I hope you enjoyed my conversation with Dr. Nathan Riley. As we said, the two of us found so much to talk about when we chatted over the telephone that we probably could have recorded 12 hours worth of audio to share with you, but we tried to narrow our thoughts down and reel them in a little bit to get down to something tangible and takeaway for you to hear about. One of the things that I really loved, that I think it's something simple for us to remember and take away, are three things that doctors can do better, but also that need to be emphasized in medical training. And the first is to slow down. And as Nathan talked about, and I experienced the same thing, medical training is always rushed, overwhelming, overpowering. There's no time for anything, and there's an emphasis on productivity and speed. The faster you can work up a patient, the more patients you can admit during a day, the faster you can present the patient and order the labs and write your notes so you can move on to the next patient. We're rewarded and encouraged to practice with speed. And that is one of the greatest errors that we make, because the true art of medicine lies in the ability to be present with a patient, to actually sit and slow down and take time with a patient. And so this emphasis on going fast is counterproductive for the type of medical care we would like to offer for actually helping patients heal and find peace and love and well-being in their lives. And along with slowing down, the second step is to truly listen, deeply listen to what patients have to say. And again, this is not emphasized at all in our medical training. I had no training whatsoever on how to actually listen to people. I had training on how to question people and was provided with lots of lists of questions and review of systems and all the things that I should ask a patient. And so the mindset of a doctor coming in to care for a patient is, how do I ask all the right questions to get the information I need? And again, it's not very helpful because our questions may be completely missing the mark in terms of what the patient actually needs to talk about or needs to share during this visit. And when doctors emphasize their own questions first, they don't have the opportunity to hear what the patient needs to say. And this requires actual training in listening, stillness, being quiet, slowing your mind down. So instead of thinking of the next question you're going to ask, can you listen and truly hear what the patient is trying to say, not only through the words they're speaking, but through the energy that they're emanating, through the body language that they exhibit as you're sitting with them? Can you listen on multiple levels to truly understand what this patient is trying to communicate with their whole being? So first, slow down. Second, listen. And we need to be teaching and modeling listening skills in medicine rather than questioning skills. And then the third factor that Nathan talked about is simply empathy. We need to foster and nurture empathy in every medical student that comes in for training. And I believe, in fact, we need to be selecting individuals for medical school who exhibit high levels of empathy to begin with, who are capable of experiencing and expressing a lot of empathy. I actually think that some of our selection process in the past has skewed against the trait of empathy, searching instead for people who are intellectually oriented, who are good thinkers rather than feelers. And so we have overemphasized cognitive abilities and placed all our emphasis on the head rather than the heart. And so we need to choose more heart-centered people to become doctors in the first place, and not people who are not capable of the cognition they would need to be doctors, but people who have both of the head and the heart of a doctor. And then when those people get into training, we need to make sure that we nurture them enough so that we don't beat the empathy out of them, as Nathan described, by overworking them and bullying them and denigrating them until they simply stop caring. So these are three qualities that need to be brought into medical training and that need to be emphasized for every medical practitioner. Needs to be able to slow down, to listen deeply to patients, and to exhibit and operate from empathy. And so I loved it. I love that Nathan was able to sum this up in just 3 things that we can all remember and think about. So that's really just the beginning of some of the things that need to happen in order to fix our broken system. But that alone, with those 3 qualities, we could make a lot of changes in how patients are cared for, both at birth and at death. So that's it for today. Remember that there will be a new episode next week, every Monday. So I have something new to say. On July 9th, I'll post another vigil for all of you to take in. And between now and next Monday, we'll be celebrating Independence Day here in the U.S. So stay safe and well, all of you out there, as you celebrate. If you enjoy this content and you'd like to be a supporter of the podcast, there are a couple of things you can do. One is to subscribe on Apple Podcasts or Spotify, wherever you happen to be listening, and then leave a review there if you're so inclined. You can also share it with other people who might benefit from this content. And if you'd like to become a financial supporter for just a small amount, a couple of dollars a month, you can join the team at patreon.com/EOLU and sign up there to give just a little bit of cash to help keep the podcast on the air. So until next week, remember, we're here for love. Love is really what it's all about. So face your fear. Be ready for whatever will come your way. And we know for sure now that anything can happen. And love each and every moment of this incredible life. Bye-bye.